Okay, let's move on to respiratory system assessment. As noted, vigilance is the key to airway management in every patient. The trauma patient whose airway and breathing initially looked fine on exam may become symptomatic with a pneumothorax or a hemothorax or a combination thereof that was not likely or not initially evident. They may seem fine on this on initial approach, but they may deteriorate fairly quickly um, and become symptomatic. The asthma patient who initially responded to nebulizer treatment may have a sudden bronchospasm and worsen right in front of you, and have auditory wheezing, retractions, accessory muscle use, um, and so forth. Um, Minute by minute reassessment of the adequacy of every patient's airway and breathing is essential. Uh, this is why we use tools to help us, but we still need to remember to keep eyes on the patient and listen. The changes may be subtle. It could be an increase in rate, worsening or onset of irregularity, an increased difficulty speaking. Assessment of the respiratory system begins with the primary assessment and should continue through the secondary assessment and the reassessment. We'll get more into those here soon, but for the right now, we're going to concentrate on the airway system, or I'm sorry, on the airway. Uh, the purpose of the primary assessment is to identify any immediate threats to the patient's life, specifically airway, breathing, and circulation problems. So we're looking for our ABCs. We're already doing that. We do that, and we've been doing that, as all of you are EMTs or better. And ABCs has been ingrained into us. But we tend to, as we get more advanced options, we tend to glaze over the ABCs a little bit, and we want to pull that back. So for patients at cardiac arrest, compressions come before airway and breathing, which is where the CAB comes in. However, as discussed in the introduction, airway assessment, management, and ventilation should be considered and can occur together. So we can do all of this at once, especially as a team. First, we want to assess the airway to ensure that it is patent. Patent meaning that it is free of obstruction, free of clear passage of air in and out of the upper and lower airways, all the way down to as far down as we can visually see and we can watch as chest rise. Snoring or gurgling may indicate potential airway problems. Means there's a liquid of some sort, blood, vomitus, saliva, something is in there that's causing that snoring or gurgling. Next, determine the adequacy of breathing. Is it a normal breath? Is it shallow? Is it a deep breath? Are they slow? Are they fast? If the patient is comfortable with a normal respiratory rate, alert, and speaking without difficulty, you can generally assume that his airway is patent and breathing is adequate. Patients with altered mental statuses warrant further evaluation. Feel for air movement with your hand or your cheek. So that's the look, listen, and feel. This is, in this instance, listening with your cheek or feeling with your cheek would be when you're down looking for chest rise, as in with CPR. Look for the chest to rise and fall normally with each respiratory cycle. I guess I should move this forward. Look for the chest rise and fall normally with each respiratory cycle. That's while you're down there, look. If you can see air movement and feel air movement, is it adequate? Again, is it equal chest rise? Is it a deep breath? Is it a shallow breath? These are all things of note. Listen for air movement and equal bilateral breath sounds. So your quick listen when you're listening to the chest of the uppers, midclavicular, just above the pectoral muscles, or and then midclavicular down on the lower side of the chest, or mid-axillary, depending on how you were taught. You're going to listen for breath sounds. Are they clear? Are they equal? Are they adventitious lung sounds, meaning that there's something else there, like wheezing or stridor or gurgling or rels or bronchi? Is there something there? Or is there nothing? Are there breath sounds missing on one side or the other? Are they diminished in the lower and normal on top? Are they, any abnormality in your breath sounds at that time is something to note. Absence of breath sounds on one side may indicate a pneumothorax or a hemothorax in a trauma patient. In an adult patient with a respiratory rate generally runs between 12 and 20 breaths per minute. Breathing should be spontaneous, effortless, and regular. Irregular breathing suggests significant problems that usually require ventilatory support. So, is it, we'll get more into the patterns here shortly, but are they Cheyne-Stokes type breathing, where they kind of crescendo and then they become shallow and rapid, and then they become rapid and deep, and then they kind of crescendo back down? Are they apnoistic, where there are periods of apnea? Are they Kussmaul respirations, where it's just a rapid, deep breathing, as within DKA? Observe the chest wall for any asymmetrical movement. Again, in a trauma patient, the paradoxal breathing may suggest a flail chest segment, where the ribs have been broken in two or more locations on two or more ribs, and now you have a segment that is moving counter to what the rest of the chest is doing. Patients showing increased respiratory effort, insisting on sitting upright, sniffing, or semi-Fowler's position, or refusing to lie supine should be considered in significant respiratory distress. They are getting positional. Their breathing depends on position. If a patient is not breathing, or you suspect airway problems, open the airway using the head tilt chin lift or the jaw thrust maneuver. If trauma is possible, use the jaw thrust maneuver while stabilizing the cervical spine in a neutral position. Again, this is a basic skill. We all know this one. Once the airway is open, reevaluate the breathing status. Are they breathing at this point? Has the snoring respiration stopped and they are now breathing clearly? Are they breathing at all? If breathing is adequate, provide supplemental oxygen and assess circulation. Consider the use of airway adjuncts, as discussed. We'll get more into the adjuncts later, but we're all EMTs, so we know what basic adjuncts we can use at this point. We can use a NPA or an OPA to help, as long as there's not a gag reflex. We can use the OPA. NPA we can use without or with a gag reflex. If the breathing is inadequate or absent, this is when we need to start bagging. When assisting a patient's breathing with a bag valve, mask, or other positive pressure device, or placing an airway adjunct, or intubation as we get into it, we're going to monitor the chest rise and fall to determine the correct usage and placement. So making sure we've got it in the right place, it's the right size, it's allowing free passage of air, and holding that airway and securing it. We move on to the secondary assessment. After you complete the primary assessment and correct any immediate life threats, conduct the secondary assessment. While continuing to monitor the airway, breathing, and circulation, this is a constant, we are always monitoring the airway, breathing, and circulation. So here's a guy using a bag mask with the C3 technique, with the 3 fingers along the bony part of the jaw, along the angle and under the chin, as well as the C shape around to seal the mask to the face. So we're going to move into history. When it's time for the patient, his family noted onset of symptoms is important information as to whether it's an acute event or that occurred suddenly, or is it gradual onset. Identifying possible triggers such as allergens or heat can also help the patient avoid them in the future. Additionally, symptoms cause course of development since onset will help direct diagnosis and treatment. So this is all going to feed into your differential diagnosis. We'll get into those later. And then how we're going to treat this. Have they been progressively worsening, recurrent, or continuous? Associated symptoms will help further assess the cause of the patient's problem. Has he had fever or chills with this? Is there a protective cough? Is there chest pain, nausea, vomiting? Is he diaphoretic or is he sweating? Does he think his voice sounds normal, or does the family think they sound normal? These are all things to consider. The patient's past medical history will put his present complaints into perspective and help to identify the risk factors for a variety of likely diagnoses. Determine whether the present episode is a similar or any past episodes of shortness of breath, what medical evaluations have been done, and what they have found. Has the patient ever been admitted to the hospital for his complaints? Has he ever been intubated? The recent history leading to the onset of symptoms is important. Did the patient run out of medication? Has he been non-compliant with his medication? Did he drink too much fluid or alcohol? Did he have a seizure or vomit? Did he eat something that might induce an allergic reaction? Did he have receive any trauma? If an injury is involved, evaluate the mechanism, looking for other injuries as well, and just understand what happened, what may be causing his injuries now, or causing his distress now. Keep in mind that blunt trauma to the neck may have injured the larynx. Anything that makes the patient's condition better or worse is also significant. So, along with the history, you want to know family history. Is there anything that the family has had? Is there COPD, emphysema, asthma, anything like that that might cause shortness of breath? Is there any congenital defects that they may know of that they may not have seen? Have they been to the doctor recently? Have they been checked out for this? If not, have they felt this way before and it just passed, so they didn't? Because a lot of people do that as well. I mean, these are things that we need to that need to be known and need to be found out as part of our history. When we get into our physical exam, with respiratory problems, you should continue to evaluate the airway, breathing, and circulation that you started. So we're going to reassess those things. We're going to continue to reassess that into the physical assessment. So now you use your physical examination techniques of inspection, auscultation, and palpation to evaluate injury or illness in more detail and determine your plan of action. We'll get more into the full assessment at the moment, but right now we're working on respiratory. We'll continue in just a moment.